In 2014, a world-leading children's hospital mistakenly injected glue into a child's brain, causing irreversible brain damage. Clinical negligence is not rare. Last year, over 13,500 clinical negligence claims were made in England, an average of 37 claims per day. It has been argued that in clinical negligence claims, the odds are stacked against patients. However, what constitutes clinical negligence? In this video, we'll dive into the world of clinical negligence, what it is, how the courts decide these cases, and the far-reaching impact it has on both patients and the national health system. Medical negligence is established when a breach of duty of care by a healthcare professional causes avoidable harm to a patient. So patients or claimants will need to prove duty of care, breach of duty and causation in clinical negligence claims. Duty of care was established in the case Donoghue against Stevenson in 1932. Lord Atkin defined it as,
"Every man ought to take reasonable care that he does not injure his neighbour, or the law gives the neighbour an action to recover damages."
When it's reasonably foreseeable that your actions may cause harm to someone, you owe them a duty of care. In a clinical setting, a duty of care is automatically created when a patient is admitted to a hospital or consults with their doctor. However, this duty is limited to harm related to medical care. For instance, your doctor's duty of care applies when they prescribe medication, but not if they give you directions to the train station. Sometimes, the scope of the duty of care is not clear. Ms. Meadows sought medical advice from Dr. Khan due to concerns about haemophilia in her family. She wanted to avoid having a child affected by the condition, so Dr. Khan ordered a blood test to check if she had haemophilia. However, he ordered the wrong test. It checked for symptoms of haemophilia, not whether she carried the gene. Dr. Khan told Ms. Meadows that her test results were normal, leading her to believe she wouldn't have a child with haemophilia. Ms. Meadows gave birth to a son with both haemophilia and autism. She argued that if she had known about the haemophilia, she would have terminated the pregnancy, thereby avoiding the birth of a child having both conditions. So, she sought compensation for the costs of raising a child with both haemophilia and autism. Dr. Khan accepted liability for the haemophilia, but not for the autism, arguing the advice given only related to haemophilia. The court agreed, holding that the risk of autism was a general and reasonably foreseeable risk of pregnancy, unrelated to the medical advice given about haemophilia. Therefore, Ms. Meadows could only get compensation for raising a child with haemophilia, but not for the autism. At the time of the judgment, it was believed that there is no link between autism and haemophilia. Interestingly, a recent study suggests a higher prevalence of autism in boys with haemophilia compared to the general population. Who knows if the outcome of the case would have been different today? The case of Khan against Meadows shows that the courts are ready to limit the scope of the duty of care, even if the claim relates to medical treatment. But who owes the duty of care, the clinician or the hospital? The answer can be found in Cassidy against Ministry of Health. Lord Denning said,
"Hospitals are responsible for the negligence of those persons in failing to give proper treatment. Hospitals are under a duty to use care in treating a patient."
This means that hospitals owe a duty of care. Hospitals can delegate the task of taking care of the patients to doctors and nurses, but not the duty of care. This distinction is important for patients. For example, patients that have suffered harm can bring a claim against the hospital even if the doctor cannot be found. In conclusion, without a duty of care, there can be no liability in clinical negligence cases. Therefore, the first step for a claimant is proving that this duty exists. In the NHS, the duty of care typically arises between the hospital and the patient, and establishing it is usually straightforward. However, in certain cases, case law has limited the scope of this duty, even when it involves medical advice. Once the claimant has established that a duty of care exists, the next step is proving a breach of that duty. This means showing that the other person fell below the standard of care required by law. But what is the standard of care required by law? John Bolam suffered from depression. As part of his treatment, he received electroconvulsive therapy. During the procedure, the doctor did not use physical restraints or administered relaxant drugs. This led to Bolam sustaining a hip fracture due to the jerky movements caused by the therapy. At the time, there was a divide within the medical community regarding whether the use of relaxants or restraints was necessary to prevent such injuries. Bolam sued the hospital. The judge held,
"A doctor is not guilty of negligence if he has acted in accordance with a practice accepted as proper by a responsible body of medical men skilled in that particular art. A doctor is not negligent if he is acting in accordance with such a practice merely because there is a body of opinion that takes a contrary view."
Bolam lost. This means that there is no clinical negligence if responsible doctors would have done the same, even if other equally responsible doctors would have chosen a different approach. This is known as the Bolam test and became significant in shaping the standard of care in medical negligence cases. The Bolam judgment has raised some concerns. It means that a doctor does not fall below a standard of care if their actions are supported by a respectable body of medical professionals, even if only a minority agrees with them. This has been criticized as it allows doctors to set their own standards, as long as another responsible doctor agrees with them, creating a doctors know best mindset in courts. So after Bolam, expert medical opinions became almost the final word in deciding whether a doctor was negligent, making it seem like the medical profession was somewhat above the law. The Bolam test is still applied today, particularly in cases involving medical treatments, where a clinician chooses one treatment from several available options. However, the case of Bolitho introduced a caveat to the Bolam test. In Bolitho, a young boy died in hospital after suffering a respiratory failure. The boy had a history of serious health issues, and when he began experiencing breathing difficulties, the nurses called for the doctor. But the doctor never arrived. The boy's parents argued that if the doctor had come, she could have intubated their son and saved his life. On the other hand, the doctor argued that even if she had attended, she would not have intubated the boy, and the boy would have died anyway. Therefore, she claimed that her absence did not cause the boy's death. Although the majority of doctors testified that the boy should have been intubated, there was a minority who agreed with the doctor's decision not to do so. The House of Lords ruled in favor of the doctor relying on the Bolam test. Since some responsible doctors agreed with the decision not to intubate, the doctor in Bolitho did not breach her duty of care. However, in the judgment, Lord Brown Wilkinson introduced an exception to the Bolam test.
If a professional opinion is not capable of withstanding logical analysis, the judge is entitled to hold that the body of opinion is not reasonable or responsible.
In essence, this allows judges to rule out evidence provided by doctors if it cannot withstand logical analysis. Bolitho did not change the Bolam test, but it qualified its use. Professor Rachel Mulheron identifies 7 ways in which Bolitho qualifies the Bolam test. Some common scenarios include when a doctor fails to observe a simple, clear precaution to prevent a bad outcome, or when a doctor fails to weight the risks and benefits of an intervention. Another scenario is when an accepted medical practice conflicts with widespread public opinion. In AB against Leeds Teaching Hospital, the hospital took organs from children who had died at or shortly after birth for research. While this was an accepted medical practice, it led to a national scandal. In this case, the court considered the community expectations and applied Bolitho, deeming the medical practice indefensible in the public's view. The judges can also apply Bolitho when there are inconsistencies in the doctor's expert testimony. For example, in Smith against Southampton University Hospital, the patient, Ms. Smith, suffered significant disabilities after surgery. She claimed that her injuries were caused when the surgeon operated with scissors without being able to see the tip. The doctor's expert witness agreed that this was the most common cause of the type of injury Ms. Smith had suffered, although it was not considered substandard medical practice. The Court of Appeal, however, found the surgeon negligent.
Basic good practice is keeping your scissors shut unless you can see what you are doing.
In summary, the rulings in Bolam and Bolitho have shaped the standards for clinical negligence. Doctors need to convince the court that their argument can withstand logical analysis. However, this does not mean that their approach is the best or ideal practice, but rather that it reflects the actions of some responsible doctors. On the other hand, patients must show that their arguments are logically sound and that the doctor's reasoning is illogical and indefensible. One reason why judges hesitate to find medical professionals negligent is that, not being medical experts themselves, judges might feel uneasy about setting the standard of care. Lord Woolf gave another explanation. In the 1950s, medical litigation was rising sharply, and judges in the UK wanted to avoid the lawsuit-heavy culture of the USA. They believed that clinical negligence lawsuits would encourage defensive medicine, where doctors might focus more on avoiding legal action than on providing the best care. Critics argue that the impact of Bolitho has been limited, as doctors continue to set their own standards of care, with courts remaining highly deferential to the medical profession. As the judge Lord Brown Wilkinson remarked,
It is seldom for medical experts to give opinions which would be considered unreasonable.
patients need to prove that the actions or omissions of the doctor caused their injuries. This is known as factual causation, and it was defined in the case of Barnett against Chelsea and Kensington Hospital. William Barnett was a night guard at a college in Chelsea. Around 3 a.m. on New Year's Eve 1965, a man broke in, stole some money, and assaulted another guard. Afterward, Barnett and his colleagues drank tea to relax, not knowing it had been poisoned with arsenic. After falling ill, they went to the Chelsea Hospital emergency room, but the doctor refused to see them and sent them home, telling them to see their GPs. Barnett died a few hours later. His widow sued the hospital, and the court found that the doctor had a duty of care and breached it, as he should have examined Barnett. However, the court also ruled that even if the doctor had treated him, Barnett would have died anyway. As a result, the widow lost the case. This case introduced the but-for test in tort law, which asks if the harm would have occurred but for the defendant's actions. So, if the actions of the doctor have no effect on the patient's injuries, there is no causation. Therefore, there is no clinical negligence. The threshold used in civil cases is on the balance of the probabilities, which means more likely than not, or above 50%. Martin Wilshire was born prematurely. A doctor negligently gave him too much oxygen, which can cause blindness in premature babies. Wilshire became blind, and his parents sued the hospital, arguing that the excessive oxygen caused the blindness. However, the hospital argued that this was just one of 5 possible causes, with the other factors related to his prematurity. The court found that it was impossible to determine which of the 5 causes was responsible, and that each cause had the same probability. This meant that each cause, including the doctor's negligence, had only a 20% chance of causing Wilshire's blindness. Since this was below the balance of probabilities standard required to prove causation, more than 50%, Wilshire lost the case. One problem with the approach in Wilshire is that if there are 2 possible causes that are equally likely, each one is considered 50% likely to have caused the harm. Since the law requires one cause to be more than 50% likely to prove it caused the harm, neither cause would meet that requirement. A similar mathematical approach is used in cases involving loss of chance, such as when a patient loses the opportunity to receive timely treatment due to a misdiagnosis. In Hodson against East Berkshire, a boy fell from a tree and hurt his hip. The doctor did not diagnose the injury correctly, and as a consequence, the boy did not receive timely treatment. By the time the boy was 20, he had developed a serious hip disability. He argued that if the doctor had diagnosed him properly, he could have been treated in time to prevent the disability. However, the court found that, even with the correct diagnosis, there was a 75% chance he would have developed the same disability. This meant the chance of avoiding the disability was only 25%, which was not enough to meet the legal requirement in civil cases of over 50%. As a result, the boy lost the case. In the case of Gregg against Scott, the court reached a similar outcome. Gregg developed cancer and had a 42% chance of being cured if Dr. Scott had diagnosed his cancer properly, but this chance was reduced to 25% due to the misdiagnosis. The judges ruled that, since there was a 58% chance Gregg would have died even with proper diagnosis and treatment, it could not be said that, but for the doctor's negligence, Gregg would have been cured. Therefore, Gregg did not meet the balance of probabilities threshold required to prove causation and lost the case. Similar to Barnett, where the patient had limited chances of recovery. The judges in Wilshire and Gregg concluded that the negligent treatment made no difference. The problem with converting percentages into legal certainties is that any chance of recovery below 51% is treated in legal terms as if the patient had no chance of recovery at all. This effectively shields doctors from liability for negligence when the patient's chances of survival or recovery are less than 51%. Interestingly, the law allows claimants to recover damages for loss of chance in cases involving economic loss, but not in cases of clinical negligence. The money awarded by the courts as compensation is known as damages. Lord Blackburn established the key principle for tort damages.
In settling the sum of money to be given, it should put the person who has been injured in the same position as he would have been in if he had not sustained the wrong.
Money cannot restore claimants to their previous position in clinical negligence. So, damages are given as compensation for their injuries, but keeping with the principle set by Lord Blackburn. The amount awarded depends on the type and extent of the injury, as well as the overall impact it has on the patient's life. The money awarded by the type of injury is set by the Judicial College. So, according to the Judicial College, what is the price of your body? Losing a hand may result in around £130,000, while the loss of an eye may lead to compensation around £80,000. Other less serious injuries such as loss of taste or a leg fracture receive less compensation. The maximum amount a patient will receive for the type of injury is £493,000 for tetraplegia or severe brain damage. These amounts are updated regularly to adjust for inflation. Patients may also receive damages for the consequences of the injury they have suffered. For example, this can include compensation for pain and suffering, loss of earnings, loss of amenity, or medical expenses. In some cases, the damages awarded for the injury itself make up only a small part of the total compensation. For instance, in the case discussed at the beginning of the video, only about £350,000 of the £24 million was allocated specifically for the severe brain injury, with the remainder covering these additional damages. This follows the principle established by Lord Blackburn in 1884. Damages should not to make claimants better off than they would have been without the injury. Clinical negligence is expensive to taxpayers and the national health system. The average successful clinical negligence claim is over £200,000. Last year, clinical negligence claims cost £5.1 billion in settlements and legal fees, roughly 3% of the national health system's annual budget. However, that only covers a small part of the damages paid. If all pending liabilities were settled today, the cost would be nearly £60 billion. At the same time, a recent report by Lord Darcy showed that the NHS has a £37 billion shortfall in investment and £11.3 billion in backlog bills.
The National Health Service is in serious trouble.